There it is. Yay. I'm so confused. I don't. Oh, here it is. Hi, Rebecca. Rebecca, can you hear me? Someone's here. It might just be the two of us. It's weird because it popped up she was joining a meeting, but I was already in the meeting. So I don't know what's going on. A couple minutes. Where's she then? Hey, where are you? This is weird because I have like people joining like two different areas. I don't know what's going on. All right, 8314. I copied the right link. Let's see which one is sharing. Oh no, that's two different links. No. Oh, I don't know how to fix this now. Darn. I don't know if everybody gets a unique link. Rebecca, are you there? I'm gonna do the chat. Oh, Quinn's here. Okay, got some people here. Why is this off? Oh. Not a good time, yeah. Come back. Let me message Brandy. She's not. I don't know why. She's got like a different meeting ID going on. That works. Yeah. Can anybody hear me? Can you guys hear me? Anyone? Hello?
Yes, we can hear you, or I can hear you.
You're like mumbling. I don't know why Brandy's like in a different meeting. So I'm trying to send her like a message. I don't know why. I feel pain. I don't know what's going on. Wait a couple minutes. Because there's like they have like a Zoom option through Blackboard, but I don't know how well it works. There's a whole bunch. Oh, there's a whole bunch of people coming in now. And come on, say. Oh, there's Brandy. Yay! I don't know because it said she was in a different. It said she was in a different meeting. Everybody enjoying the snow. It's supposed to snow some more. I'm like, I can't. I'm over it. All right, I'm gonna record this. Is it recording now? Okay, it's recording. So I'll make sure we have it recording because I know, the other people might have like different responsibilities that they have. Their kids might be home from school. Chapter 12. Let me just move this. Can you guys see the PowerPoint screen?
Yes.
Okay. Yeah, there you go. All right, look at this. Like, I'm not used to doing this on my laptop now. All right, today we're going to be covering chapter 12, which is on blood. This works. There we go. So this is in your Blackboard, your learning module. This is just some information that is being covered there. We kind of started off with going over different types of blood cells. So there's red blood cells, also called erythrocytes. White blood cells are leukocytes, right? And then just very generally the function, you don't have to worry about the number present, but just generally the function. Erythrocytes transport oxygen and carbon dioxide. A good round value is like 5 million per cc. There's a different range of numbers for males and females. We'll go over that, I think, a little bit later on. And then white blood cells, in general, they fight against foreign pathogens. That could be parasites. They also help to remove worn cells. And there's two groups of white blood cells. There's the granulocytes and the agranulocytes, and their classification is based on whether they have granules or not have granules. And granules are little like specialized storage containers that are found within these cells. So the types of granulocytes are neutrophils, eosinophils, and basophils. We're not going to be identifying them microscopically. And they're kind of we'll go through just an easy way to remember like the normal like prevalence or levels you should have. And so neutrophils phagocytize small particles, which means they're just able to engulf bacteria, debris, it could be like other cellular waste, and destroy it. Eosinophils, most generally, they're involved in parasitic infections, helps to moderate allergic reactions. So if somebody was hospitalized and they were undergoing a severe allergic reaction, you could actually enumerate, like on a slide, the percentage of different white blood cells present, and the eosinophils are generally very low percentage of total blood cells. But you can see on this slide says 1 to 3%. So if they're very highly elevated, that could indicate that there is a parasitic infection or allergic reaction. The basophils, they are the least numerous of the white blood cells, and they relieve oops, that just flipped by itself. They release slides over. They release heparin, which helps promote blood flow to area, and histamine, which helps make capillaries a little bit more permeable. And so the idea is to try to enhance the ability of white blood cells to reach an area of infection. That's the function of heparin and histamine. Histamine, increasing permeability, particularly like in the sinus area, that can make you feel very congested or stuffy. You take an antihistamine. You have too much histamine. And then the agranulocytes, so the difference is that they don't have these special storage containers or granules. There's two types. There's the monocytes, and they are, again, we're not going to look at them histologically, but they're very, very large. And they also can phagocytize, but in this case, large particles, right? And then the lymphocytes help provide immunity. So not going to all the classification, but for instance, there's B lymphocytes, which produce antibodies, would be an example. So there's several different types of lymphocytes, but they function in immunity. And then you have the platelets or thrombocytes, which are actually a kind of a fragment of a megakaryocyte, don't worry about that, fragment of a very larger cell found in your bone marrow. And they helps to control blood loss. So that's kind of like a quick review. Okay, which brings us to hemostasis, which means the stoppage of bleeding, right? So if you have a type of vascular injury, you cut yourself, there are 3 processes that come into play to help to slow down or prevent blood loss. Right? So the thing that happens first is a vascular spasm or a vasospasm. So the area surrounding the injury is going to kind of contract inward to help try to prevent blood loss. And the spasm, which happens pretty quickly, is like kind of effective for about a half hour. All right, you know what? Let me just go back. I'll go over these kind of quickly because they're on the following slides. And then platelet plug formation. Let me wait till we get there. And then blood coagulation. All right, so if you have a various cut in a small blood vessel, the muscles in the wall of the blood vessel, they're going to contract. It's going to kind of push inward. And that's a vascular spasm or a vasospasm. Right. So it's a reflex that occurs due to vascular injury. It only lasts a few minutes, but its overall effect could be about 30 minutes. And so this is kind of not a very effective way to stop bleeding, but it kind of kicks off the whole event. And so by 30 minutes, the platelets or thrombocytes, they all start to kind of like stick together. I was thinking, I have to make it weird. I think of like holding hands. So they stick together and they form a plug. And then after the plug is formed, that's when blood coagulation will start, right? Vasoconstriction, either it's like the muscular spasm, the blood vessel vasoconstricting. I don't know why this thing is advancing by itself. Vasoconstriction also helps to decrease blood loss at the site of injury. So you can see it's like kind of pinching inward. You can see there's red blood cells that are exiting, but you're trying to make the opening a little bit narrower. So not as much blood is flowing through the area to be exiting out of the vessel. All right, so the platelets, which are very tiny cellular fragments, and normally they're just flowing along inside your blood vessels. You have endothelium, which is lining the blood vessels, which provides a very kind of like smooth, slick layer. And the platelets, they're going to tend to stick to any like rough surfaces. And so when you cut the blood vessel, the underlying connective tissue, which contains collagen, becomes exposed. And so now the platelets, now there's this rough area that's been exposed. They're going to adhere to this area, right? So they're going to stick to the exposed edge of the blood vessel, and they're going to kind of all grip onto each other. And so they form a network with spiny processes. So they kind of become pointed and they try to overlap. And this forms a plug, right? So they stick to each other, and then they're going to try to fill in the area where there's a vascular injury. And this is, probably like effective enough on a small blood vessel. So tell me I need to go faster. Okay. Oh, so this is showing the mechanism of hemostasis. So we said first you have the blood vessel spasms, then you have the plug that forms, and the blood clotting is just reinforcing the platelet plug, right? And it's kind of a cascade reaction where you want to have all the factors that are necessary present in place so that can occur very, very quickly, but you don't want blood clotting inappropriately, right? So there's kind of the platelets release factors that then kind of kickstart this event. You have prothrombin converts prothrombin to thrombin. And then I just have a kind of star at the one area we're going to kind of look at. So you have a protein called fibrinogen, and then that becomes activated and becomes fibrin. So I always remember fibrin like fiber. And it's this fiber that is going to now reinforce the plug. And then you have a formation of a blood clot. So there's a variety of different types of hemophilia, but that's a genetic disorder where you have an absence of a particular clotting factor that inhibits the body's ability to form blood clots. All right, this is like the nice slide, and we're just going to do fibrinogen to fibrin. Here's like the real, so this is like the real reaction. I don't know, they were naming these factors Roman numerals in order, but then it was kind of found out that there were some reactions that occurred in between existing reactions. So the numbers are kind of all over the place, but you can see like all the way on the right side, they have fibrinogen becoming fibrin, which is like a fiber. It's like cross-linked protein threads. So yeah, it's kind of pretty complicated reaction. We're just going to kind of look at the very end of it. But just know that these factors are all present in your blood, and then they're able to then kind of cause this cascade to occur. It can be triggered inside the blood vessels or externally, which would be like the collagen outside the blood vessels. That's just where it says like extrinsic coagulation, extrinsic, and then there's like common pathways. So the platelets are very, very, very tiny. So they're really not visible here. So this is showing red blood cells, which kind of look like little donuts. And then the yellowish threads, that's the fibrin. So the fibrin's like kind of like a net or a reinforcing. I'm not advancing this. It's like slowly going on its own, reinforcing, right, the platelets. And of course, you're going to have trapped red blood cells that are in that. Right. So sometimes there are blood clots that form abnormally in a blood vessel. This could occur maybe in deeper veins of the legs. It sometimes occurs in an area where there's blood pooling. So that could be like the lower extremities, especially if individuals kind of stationary, right, and not moving. It may cause the blood to kind of pull together. And I'm reading this and I'm just thinking we also have to finish chapter 13. So let's do this. Then we'll flip back to 13 because I'm like, wait, we didn't. I'm thinking deep veins, and I'm like, I know that was in chapter 13, so I apologize. So we'll finish 12, but then we'll just kind of go back to 13. You don't really need to do one before the other. Okay. So if you have a if you have a clot that forms abnormally in a blood vessel, I gotta be honest, I don't have my notes at home with me. I just thought for sure we'd be back at school today. So you have a thrombus or a blood clot that forms. And then if it dislodges and starts to travel through your blood, then it's called an embolus. So that's the only difference between the two. An embolus is something that is moving. So again, in areas where blood starts to pool or where you have kind of blood vessels that split into a Y and you maybe get pooling at the branching point, these are areas where blood vessels can start to, where embolism can start to form. And these abnormal blood clots, they can travel through the blood and they can be very serious or very fatal. So if it reaches, right, the coronary arteries of the heart, then it's called a coronary thrombosis. So that's a clot in a vessel that supplies blood to the heart. If it travels to the lungs, where it can actually block for the lung, that's a pulmonary embolism. So it's just the name is just kind of referring to where this clot has lodged itself. An infarction is where there is a restriction of blood flow. So you could have a blood clot that blocks blood flow, within the coronary arteries themselves. And so that's a myocardial infarction or also a heart attack. So I think last week we talked about that. You could have a heart attack that's due to the breakage of yellowish fatty plaque that has adhered inside the coronary arteries. Okay. But it also could be heart attack could be caused by having a blood clot that blocks one of these vessels. Right. So yeah, we discussed last week atherosclerosis, and that's where you have, the building up of fatty deposits. And these areas themselves, okay, so we said the atherosclerosis, the fatty deposit can break off and block an arterial wall, but anything that's kind of restricting the free flow of blood, causing it to pool, or maybe just not flow in a complete direction, can sometimes cause abnormal formation of clots. Sometimes individuals that have like maybe a heart valve replaced sometimes go on blood thinners. That's another thing that can potentially cause like the formation of blood clots. All right, so we're talking about this week. It's showing on the left a normal arterial wall, and then on the right how the opening is becoming smaller due to this plaque that has accumulated on the arterial wall. All right, so the next section is on blood groups and blood transfusions. Right. And so in order to receive a blood transfusion, the donor and recipient blood must be compatible. Okay. So we'll get into a little more detail. So there's about 30 different groups of antigens. These are just unique markers that are found on the outside of your cells. That allows your body to identify your cells as being part of your body. And then you have immune responses to antigens that are foreign. So there's about 30 different antigen groups found on red blood cells, but it's just the ABO blood groups or blood types that are critical in giving a transfusion to an individual. And then we'll also get into RH factor. Stay with me, please. I'm talking on the screen. Okay, so antigen, these are unique markers. They could be sugars, they could be proteins. In this case, they're glycoproteins. That just means a sugar protein. It's a molecule that sits in the cell membrane of a cell, and that it functions as like a little flag or a little indicator. Okay, so you have self antigens, which are fine, which aren't going to cause immune response, but foreign antigens will. Foreign antigens will invoke an immune response. The way this response occurs is that your body produces antibodies, and these are proteins produced by the immune system, and the antibodies will target a specific antigen. And it's not just for red blood cells, so that's what the conversation is about, but antibodies target foreign substances that are found in your body. Okay, and what it does is always your antibodies looking like kind of like a letter Y. It pulls together these foreign substances, kind of like aggregates or pulls them together. And then this is called agglutination, right? So coagulation, these are easy to confuse. Coagulation is a formation of a blood clot. Yes, I can hear you kind of. Is that a comment?
I'm sorry, that was me. I accidentally hit that.
Oh, that's fine. That's fine. I was just like, okay. So agglutination is where you have the clumping of red blood cells, but it's due to immune response, right? So you're going to have red blood cells and platelets and fibrin forming blood clot. This is grouping together of just the red blood cells. So it doesn't involve the platelets at all or the clotting factors, but it's the antibodies that are going to pull all these foreign cells together and then targeting them for destruction, right? So it's like, you don't belong here, you don't belong here, you don't belong here. We're going to like put you all together and then we're going to destroy you, right? So when red blood cells, when they agglutinate like this, they're pretty fragile. I mean, they only live about 4 months, right? So they're always being produced and then they get a little bit damaged or, and then they're destroyed and they're regenerated. So they're produced all the time. They're a little bit fragile. And so when they're agglutinated, it causes them to rupture or to burst open, right? So it's like somebody's pulling on really hard and it's, kind of snags part of them off. And then that can get to the middle. I could kind of go to the bottom. So that causes a transfusion reaction, right? So the red blood cells releasing in your bloodstream, because it says on there hemoglobin release. So lysis of red blood cells, hemoglobin release can cause organ failure. It can cause you to go into shock. It can cause death. Okay. Other things that occur in a transfusion reaction is, you may feel anxious, have breathing problems, feel flush, have severe pain. So transfusion reactions can be deadly, right? They can be deadly if you're given like the wrong type of blood, right? So the little dot in the middle, when transfusion reaction occurs. All right, so your antibodies in the recipient's plasma, which is the liquid fraction of your blood, that's where your antibodies are formed. They're going to pull together or agglutinate, and the way that they can attack these foreign red blood cells is by recognizing these antigens as being foreign, right? So your antibodies, and it's weird because antibodies produced in regards to blood cells, I think it takes to like 3 months after birth for them to fully form, right? So it takes a couple of it takes a little bit while, but this is a type of immunity that's innate or born with. But in reality, it takes like a baby a couple of months to have this developed. All right, maybe I'm going to go forward to and back one so it doesn't flip the middle of me talking. Okay. Okay, so this blood group is based on the presence or absence of two important antigens on the red blood cells. Okay, so there's antigen A and antigen B. The way that you have type of blood is, and you can think of it as maybe 0, but you still have antigens there. If you don't have an A antigen or a B antigen, that makes you have type O blood. And blood types are inherited from your parents. If you have type A blood, that means you have type A antigens on your red blood cells. And if you're type A, the type B antigen is foreign. So you're going to have anti-B antibodies or antibodies to the B antigen in your plasma. If you have type B blood, that means you have B antigens on the surface of your red blood cells. And so what's foreign to B is to have A. So you have anti-A antibodies in your plasma. So there's people that have both types of antigens and they have type AB blood. And so you can't, or you don't have antibodies to your own antigens. So if you have type AB blood, right, you're not going to have either type of antibodies in your plasma. People that are type O, it's not really that it's 0, but O means that you don't have an A antigen or a B antigen on your red blood cell membranes, but both A and B are going to be considered to be foreign. So you're going to have both type of antibodies in your plasma. Go forward 2 and back 1. So it doesn't flip on me. Right. So this is showing type A blood, and they are showing the A antigen as little orange circles. And then antibodies again kind of look like a Y. So each spoke of the Y were like the little green, I don't know, like M's or something, that would be pulling red blood cells together. So that's showing that there's anti-B antibodies. And then the reverse for people that are type B, they have B antigens, and then they have anti-A antibodies. Okay. If you look at the person that has AB blood, both antigens, but neither type of antibody, right? And then people that are type O, they don't have A or B antigens, but they have anti-A and anti-B antibodies. Right, so antibodies of one type will react to antigens of the same type, right? So if you have type A blood, you have type B antibodies. So if you receive type B blood, that's type B antigens, and then that will cause agglutination. All right, the middle part, it's a good explanation, but it kind of takes it like a little far, not far out, but a little maybe out of the range of what we need to know. So the main concern is possible agglutination of donor red blood cells from the antibodies in recipient's plasma. All right, so if you have a person, the recipient has type A blood, the antigen on the red blood cell is A, we know that, and we know they have anti-B antibodies. This person cannot be given a transfusion of red blood cells containing the B antigen. All right, that makes no sense. The one in the middle, what it's saying is, I've type A blood. If you gave me, so we'll get to, let me pause right here and explain this. All right, so if you have type O blood, you don't have either antigen. So in theory, since there aren't any antigens present, you could give type O blood to anybody. But if I'm A negative, but if you gave me O blood, I'm going to get a little bit of the A and B antibodies from that person's blood, right? So I'm going to get a little bit of their antibodies. But when you get a transfusion, you get packed cells, and the number given is negligible. But however, when they give transfusions, they will give you your type specific unless in an emergency. All right, I'm going to come back to that because I need like better explanation. All right, maybe this will explain a little bit better. Right, so this again is just summarizing, what antigens people have, what antibodies is present. I'll go over that again with this slide. Right, so if you have O, you don't have either antigen, so you could give your blood to anybody, but there is going to be a small amount of antibodies in the type O person's blood, that could react. So if I got O blood, I'm getting some anti-A antibodies, which potentially could cause a breakdown of a very small percentage. Just like in school, I start coughing. Very small percentage of my red blood cell, but I'm receiving trillions of cells and a very small percentage breaking down. It's not going to be significant. Right. Right, so this is showing normal blood on the left. The cells that are kind of purple in color, that represents white blood cells. So that's a normal blood smear. On the right, you can see everything's all clumped together. So that would be showing an agglutination reaction. All right, so universal donors and recipients. Okay, so people that are AB, right? So they have A antigens, they have B antigens, but they don't have any antibodies to react with any of the other blood types. So they're called the universal recipient. So you could give somebody that has type AB blood, A blood, B blood, obviously AB blood or O blood, right? So they can receive from any of the other blood types since they have no antibodies found in their bloodstream to agglutinate with potential foreign antigens. People that have type O blood, they're referred as a universal donor. And this is because they don't have any antigens on their cell membrane that would cause a reaction into whoever the recipient is, right? So type O red blood cells can be transfused to a person with any of the 4 blood types, right? Since the red blood cells will not be attacked by blood antibodies. Let's make sure this works. Oh, there's so many people in the waiting room. Sorry, people in the waiting room. I've like not done this on my laptop in a while, and it's not going well. Usually they makes like a bing or doorbell sign. Well, this is all going to be recorded, so if you missed some of it, can everybody see the blood typing game? So this is actually it's from the nobelprize.org, and what it just has a lot of information about blood typing, how blood typing is done, how do you determine a blood type. It goes through like the ABO blood system again. The RH factor is a little bit different. Now, sometimes it's called antigen D. RH comes from rhesus monkeys, where it was first discovered. And this is a factor that either you have it or you don't have it. So that's why it's referred to as either being RH positive or RH negative. What's unique about RH factor is if you're RH negative, right, you do not have any antibodies to the RH positive factor unless you've come in contact with this antigen previously, right? It's similar to if you develop immunity to disease. So if you develop natural immunity to the measles, it's because you contracted a measles infection, or you could develop immunity to measles because you received a measles vaccination. But before either of those events, you don't have any antibodies to the organism that causes measles. So for the Rh factor antigen D, an individual doesn't have any antibodies unless they've been exposed to it once, right? So this can cause a agglutination reaction, right? But you had to have been previously exposed to it. So when we get back into the PowerPoint, we'll go through the one situation where this becomes a particular concern. All right, so I'm going to do. All right, so this is the blood typing game. All right, so we're gonna get our patient's blood. You know, it's weird because I have like everyone's names blocking my screen. I'm supposed to be hitting here. What is this? There we go. Everybody's name was like over the next. So I'm like, that's a problem. Okay. So we're just going to kind of go through like what would look like when you do blood typing, and then we kind of already know like what blood types you can give individuals or which ones you can't do individuals. We're not going to do blood typing in lab, but it's just kind of interesting to watch. So when blood typing is done, this is showing tubes. In lab, we sometimes do this with like little plastic trays, but these tubes, right, contain antibodies to A is in the A tube, antibodies to B is in the B tube, and Rh antibodies are in the Rh tube. And so by adding the samples of blood into the tubes, you're looking for agglutination or clumping, and clumping indicates that the person has those antigens, right? So you are trying to initiate a agglutination reaction for you to determine what antigens are present. This is not what you would want to have occur when doing a transfusion. You do not want to have a agglutination reaction. Right, so you can see the A tube, all the blood is kind of pulled down to the bottom. So we know the individual has A blood, right? And so they don't have B antigens, so they don't have B blood. And their Rh tube doesn't show any clumping at all. So they're A negative. All right, so here's our person that has A negative blood, and we need to give them 3 bags of blood for them to be able to recover. Right, so we don't want to give them B negative. Could give them O negative.
Yes.
Sorry, it's a little loud. O is a universal donor, so you could give them O negative. You can certainly give A negative, A negative.
Yes.
Okay, and then what do we have down here? We have another O negative. Again, usually you'd only give O negative like in, kind of an emergency situation.
Yes.
Oh, we got a 5 blood score. All right, so we'll try. We won't be as kind to our second patient. So this is linked on Blackboard because it's got like good information about blood typing. We'll just do like 2 of these individuals. And then I think there's like another one that's on there. All right, so they don't have A antigens, but they do have B antigens, and they have Rh antigens. So they're B positive, B positive. All right, so we should give her B positive blood, okay, or O positive would also work. B positive, B positive, B negative. Okay, generate more bags. All right, we need B B positive. We'll give them one good one.
Yes.
All right, let's throw on some A negative, see what happens. That corrects me up every time. All right, and then you wouldn't want to give somebody that's B positive, A positive. Or maybe. All right, we could give her O negative. Okay, or if you're B positive, you could give a person B negative. So you can't give
Yes.
negative people positive blood, but you can give positive people negative blood because the positive means you have the antigens. If you have the antigens, you're not gonna have the antibodies. Give you O negative. I'm on my O negative work. Get more bags. O negative. Where's like sweat? All right, I was trying to remember the right blood, but it wasn't there. All right, we need one more. We need another B positive. Positive, maybe positive. O
Yes.
negative. O
Yes.
negative. B positive. The B positive like won't drag and drop. What? I'll try one more time. Lady, we're trying to help you, but it's not working. O positive.
Yes.
We managed to save them. All right, we only got a blood score of 2. All right, let me share. You guys are back. Oh, this one's crazy. In our absence. Okay, so we did this one. You guys, everybody can see back to the PowerPoint. I just want to make sure we're in the right spot. Okay, so yeah, so we did the blood typing game. Let me just go back one. So this is like it has preferred blood types, which usually you would want to stick with that, but it also lists permissible, which means you would not have a reaction, right? So negative people, if we're just looking at RH, can only get negative blood. If you have positive, RH positive or antigen D, you can get positive or negative blood, right? So A people you'd want to, if you're I'm A negative, you'd want to give A negative, but O negative would be fine. A positive could get A positive, A negative, O negative, O positive. B negative, just B negative, or is it making sense? B negative or O negative. And then B positive, preferably B positive, but also if you're positive, you can get B negative, O negative, or O positive, right? So it shows for A, B negative, you can get A, B, and O, but they both have to have a negative RH factor. The AB positive is really individual that can receive any of the blood types because it receive positive, negative, AB, right, or O. If you're O negative, you can only receive O negative, though a pretty high percentage of population is O negative. And then if you're O positive, you can get O positive or O negative. Right, so let me just go make sure this doesn't flip.
Professor,
Yes.
I don't think the PowerPoint is showing.
I asked you guys that. All right, let me get it back. Sorry. Where is it? Yeah, just let me know because I'm like got like a weird view going on here. All right, so yeah, so the RH factor was named as first identified in rhesus monkeys, and it's often called antigen D. And if you have that factor, you're RH positive. And if you don't have that factor, you're RH negative. And everybody's name, I'm having problems because everybody's name is like covering half the screen. I'm not sure how to fix that. So I have to like blank everybody away. Okay. So there's no corresponding antibodies in your plasma unless a person with RH negative blood comes in contact with RH positive blood, specifically the RH positive antigen, and then you would develop the RH antibodies. So where this becomes an issue is there, there's two ways if you're Rh negative that you can come in contact with Rh positive blood. So one is in a transfusion. So again, I'm A negative. If I was given A positive blood, I wouldn't have a reaction the first time, but I would then develop antibodies to the Rh factor. This also can occur during pregnancy. So if you have a Rh negative woman carrying an Rh positive fetus, during delivery, there's usually a mixing of the fetal and maternal blood, and that would then expose the Rh negative mother to the Rh positive factor, right? So not an issue really in the first pregnancy, but in subsequent pregnancies, the Rh antibodies are present and they can cross the placental barrier and attack the blood of the future Rh positive baby, which is really unique because you could have type A and you could carry a fetus that's type B, and that group of antibodies doesn't cross the placental barrier, but antigen D antibodies or Rh antibodies do, right? So if you're Rh negative woman in subsequent pregnancies, these antibodies can cause a condition, erythroplastosis fetalis, right? Or hemolytic disease of the fetus or newborn. So some of the fetal red blood cells would be destroyed. Oh, it's not on here, but the drug is Rogam. It's like RHOGAM. So that is a medication that is given that then destroys the presence of these antibodies, right? And they would usually give this medication even during the first pregnancy because there could have been an issue where maybe like you miscarried or something and like didn't know you're pregnant. So it's just like safer to do it, with the first pregnancy and subsequent pregnancies. So that's where there's issues of Rh incompatibility. Okay, and then the babies are born, they're very anemic. They might be jaundice also. Um, historically they maybe required like a blood transfusion, but now the medication's very, very efficient in preventing this from happening. All right, so Rh negative female with Rh positive fetus, okay, during childbirth, cells from the Rh positive fetus may enter into the female's bloodstream. The female's now sensitized and will produce these antibodies, which are then able to cross the placental barrier and attack the fetal red blood cells. I'm just going to leave these forward. I know, they like popped up all at once. All right, so arith means red. And then it's just like hemo, hema means blood, like hemoglobin. Leuco is the word part for white. Osis, which I think we covered previously, means abnormal condition. When used in terms relating to blood cells, that means abnormal increase. Like erythrocytosis or leukocytosis. So that's an abnormal increase in red blood cells or white blood cells. Poiesis means to make or produce. Stasis we did already. We did that. We talked like the term metastasis. So stasis we covered previously. And then thromb for clot. Is everybody good? Somebody say something. Good. So I say
Yes.
something. Okay, thank you. I was like no read here. It's like, right. So in some of these terms, the like the word group for blood is implied, but it's not directly stated. So red cells are red blood cells. I'll do the first one. Right. So it's erythrocyte. So it doesn't have like hemo or hemato in there. So the word root for blood is not included. So this is when they say it's like implied but not included. So you wouldn't just say red cell, you would say red blood cell. Ooh, stoppage of bleeding. Anyone? Stoppage of bleeding. First thing we did.
Spacious.
Yeah. Hemostasis. Stoppage of bleeding. If this does one more time, I'm gonna cry. I really am. It's like we try to like rework like schedules and things, and it's like crazy. It's almost like the pandemic. No, it's not. I'm having like PTSD. I'm teaching this class at home. Ooh, a blood clot cell. Could say platelet or yeah, also known as thrombocyte or thrombocytes. Right. If you have an elevated white blood cell count, ends in osis. This one's a little the word let me just do it. I'll just do it because it's a little difficult. Yeah, so it's leukocytosis. So again, like the blood, there's no hemo-hemato there, but it's abnormal condition, but with blood cells, it means abnormal increase in white blood cells. So like if you are fighting some type of infection, right, you might be suffering from leukocytosis. Oops, where's my screen go crazy? Formation of red blood cells. We need red. We need a formation. I'm trying to write down so many. Erythropoiesis. Which means like if you look at it, it's like formation of red, right? So like the blood part is not like fully in the term. Right now, I as soon as I went through this stuff, and then as soon as I started teaching, I'm like, we never did finished chapter 13. Okay. Because I didn't, if you were here, I was complaining earlier. I thought we'd be back for sure. I didn't bring home any of my Tuesday stuff. Now I need to get back in the office because now I have like our tests are at the printer. They're in process. They haven't been printed. So that's getting me a little stressed out. Now I have stuff that I can only do there that I can't do here. I mean, I could run them off of the copier, but I sent them to printing. They should be like done, but a couple of other things. I gotta do the testing center. That mail that. Oh, there's like a labeling the heart thing. There some other like extra videos in here. Where were we in chapter 13? take a wild guess. To be it. You guys, you probably don't have your notes home either.
Capillaries.
Capillaries. Like last week, it was, I don't know, one day it was like 1% chance of snow. Oh, here we go. We gotta go down this because we did like this part. Blood vessels, arterioles, capillaries. All right, can you see the screen? This thing's going crazy. Do you guys see the screen?
No, it's still white.
Yes, it's white. Do you see
Yeah, it's the
capillaries?
last. No, I think this is the last slide of the blood.
What was that?
I think this is the end of the blood slides.
Let's see. Why? I hate to say this, the other computer works better. All right. Okay. I'm not used to doing this on my laptop. That's a problem. Right, you see capillaries? Capillaries?
Yes.
Anybody?
Yes.
Okay. Thank you. All right, so we're going through different types of blood vessels. So capillaries, our blood vessel, they have the smallest diameter. So you have arteries, and then arteries branch into small arteries, which are called arterioles. Then you have the capillaries, and then small venules, and then veins. So that's kind of how the categories or vessels are divided by size. So the capillaries, they only have a layer of endothelium. So we mentioned that arteries are very elastic. There's a lot of smooth muscle. When you get into arterioles, the band of muscle becomes much smaller. Connective tissue becomes a smaller band. And so now we just have a layer of endothelium, right? So there's little slits that are found in between the endothelial cells. It's calling me. Uh-oh, that's not like an M alert thing, is it? Somebody from Brits are calling me. Oh, we have regular school tomorrow. Yay! See, now they're calling my house. Hang on. Yay! Regular operations tomorrow. I'm excited. Okay. So anyway, all right. So the little slits, and that allows tissue fluid to exit. Inside that tissue fluid, there's going to be nutrients, there will be hormones, be oxygen, and then it's also going to allow fluid to go back in the other direction. I just got the email. Back in the other direction. Things blown up at once. The other direction, because you're going to have waste products and carbon dioxide that are going to need to go into the capillary. So the density of capillaries is going to vary from one body part to another. Areas that have like a greater level of metabolic activity, for instance, like the large muscles in your legs, are going to have higher density of capillaries, right? So depending on typically the oxygen need that's required, that's going to depend on the densities of capillaries present. If people you start lifting weight, you don't generate more muscle fibers, but the muscle fibers that you have become larger, and they actually increases the size of the capillary beds. So skeletal muscles, like if you're walking or like you're lifting or running, they require a lot of oxygen for that to generate the force to actually move your body. So the densities of capillary beds, even in an individual, can vary depending on basically what kind of shape you're in, right? So if you're very, very muscular, you're going to have more capillaries going to those areas, right? And then you stop, I don't know, you're running, you stop running, muscle fibers get thinner, capillary beds kind of shrivel up, okay? There's little round muscles which are called precapillary sphincters, and they're going to regulate the amount of blood that goes into a capillary bed. So if you just had a meal and you're digesting nutrients, you maybe need more blood in that area. If you're outside and you're exercising, probably need more blood to that area. So you can kind of shunt where blood is going, and it depends on basically the oxygen need, like the oxygen need in a particular area. So all your cells need oxygen continuously, but if it's like you're exercising or there's a lot of metabolic activity, that area is going to require more oxygen than other parts of your body. So this is like showing, an arteriole, and then it's branching into capillaries, right? And then you can see it's kind of shifting from a red color to a blue color as oxygen is lost and carbon dioxide is picked up. So you have, like a venule, an arteriole, and the capillary is what is connecting the two. Right, so venules, they are leading from these capillary beds, and then they're going to merge to form veins, and then you would have even larger veins, eventually returning blood to the heart, right? So you have superior or inferior vena cava are the largest veins, and then lab, we looked at some of like systemic veins and arteries, like renal artery and renal vein. So if you looked at the renal artery, when that enters into the kidneys, that has some of them interlobular arteries, arcuate arteries. So it's small arteries, arterioles, capillaries, venules, and then back to the renal vein. So the walls of the veins, they have the same layers or tunics as the arteries, except the muscular layer is thinner. Blood isn't under as much pressure. They don't need to be elastic. And veins have valves. They have valves to prevent the backflow of blood. Okay? The opening in the middle of an artery or a vein is called the lumen. And the lumen is typically larger than that of the corresponding artery. So like if you had a slide of the brachial artery and the brachial vein next to each other, the opening in the middle of the vein is a bit larger. At any given time, most of the blood in your body is actually in your venous system. So they act as a blood reservoir, right? So their openings are wider, there's more blood contained in your veins than corresponding arteries at any given time. The blood pressure in the vein is going to be much lower than that of an artery, right? Because blood pressure is greatest in the blood that's exiting off the aorta, and then say it goes into the thoracic, abdominal aorta, renal artery, through the kidneys, renal vein, inferior vena cava, like the pressure is going to start to drop the further that you get away from the heart. There's like a picture on that. Oh, sorry, there's differences in the inside diameter. So this is showing like a venule and an arteriole. The opening in the top picture of the venule is much larger than that of the arteriole. And then the middle layer, the muscular layer, is much thinner in the venule compared to the arteriole. Just the question is, if your blood pressure drops, so like if the pressure and usually blood pressure could be the pressure inside any vessel. Usually when we say blood pressure, we're referring to arterial pressure. So if the pressure inside the veins is so much lower, in the arteries, think if you're standing and you have veins like in your feet or lower legs, like how's that ever going to get back to your heart? Right? So there's a couple of features that allow venous blood to return to the heart. One is the presence of valves. Your veins are typically very superficially located, and they're associated with your skeletal muscle. So when you're walking and your calves are contracting, that's pushing on the veins. That's helping to propel blood, right, in one direction towards your heart, and the valves prevent a backflow. So if blood is squeezed towards your heart, even though you're standing, it's not going to drop back down your feet because the valves are going to prevent it from going in the reverse direction. Right? So your valves, the valves are important to help return venous blood to your heart. Right? I mean, I was just mentioning that, veins being superficial as you're contracting your skeletal muscles, it's squeezing on the veins. The blood can only go in one direction due to the presence of the valves. So they kind of call that the skeletal pump. Right? So it's helping to pump blood, just the contraction of your skeletal muscles. And then your respiratory pump. So when you breathe in, your diaphragm, which is like a round dome-shaped muscle, right? When it contracts, it pushes downward, and that squeezes on your abdomen. And that, in a similar way to the skeletal muscles helping to push blood back to the heart, this helps to move blood back toward the heart from your abdominal organs, your abdominal viscera. Right, so it can only go one direction. So any squeezing is then going to have it move back towards your heart. So just the contracting of your diaphragm, your skeletal muscles, and the presence of valves all assist in venous blood being able to be returned to the heart. So this could be like your gastrocnemius, your calf muscles, actually like kind of two muscles that are bundled together. Right? So if you have the vein that's in the middle, and then as the muscles are contracting, right, it's pushing on the blood, it's pushing it toward the heart because the valves are ensuring that it can only flow in that direction. So, like, what can sometimes happen is if somebody's standing, like their job requires them to stand for a very long period of time, the blood is going against gravity, and you're not having like the assistance from the skeletal muscles. So that can cause varicose veins. So varicose veins is where you have damaged valves. So you have blood that's kind of going with gravity, and it's pushing against the valve, and then the valves can get damaged. And then, the blood then can start to pool, because it's not ensuring one-way flow, it's allowing it to kind of remain like localized, and then that starts to stretch out the veins. So this is common like in the greater saphenous vein in the leg, because this is a very, very superficial muscle. So very superficial muscles aren't as well associated with your I say muscles, very superficial veins, sorry, are not associated with your skeletal muscles. Right? So sometimes they call that like spider veins that can occur. And then these can be either like surgically removed, because the great saphenous vein, remember, you can use that for cardiac bypass surgery. And veins are very like irregular, and there's a lot that aren't even named, and they'll rework themselves. So it's easy to remove a damaged part of a vein, right? Or even remove it to do bypass surgery and not have it affect your overall circulation. So other than looking kind of unsightly, varicose veins can also be like very, very painful, right? Because you're having these stretched veins can hurt. Right? And then we have hemorrhoids. So that's when you have swollen veins, same thing, do damage valves. in the veins of the anal and rectal area. So you're going to have external hemorrhoids or internal hemorrhoids. So this is kind of reviewing characteristics of blood vessels. So we discussed the arteries are very strong. They have 3 layers. The inner layer is continuous with that of the heart. And same thing with the other vessels. They all have endothelium as the innermost lining. The arteries have a middle layer of smooth muscle and elastic tissue, and that allows them to be able to expand and then collapse due to pressure of blood, right? So it says function, arteries under relatively high pressure. The arterioles, the wall is thinner. Smaller arterioles have endothelial lining, some smooth muscle, some connective tissue. The capillaries are just endothelium. And endothelium itself consists of simple squamous epithelium. It has, remember, those like little slits that allow fluid to exit. This fluid can contain nutrients, can contain hormones, gases. Also allows wastes will then enter more into like the venous end of a capillary. Usually the oxygen nutrients are like exiting the arterial end, and then there's fluid that's pushed back to the venous end, which would have like waste in carbon dioxide. The venules, a thinner wall than arterial. And again, you're not going to have as much muscle tissue in the venous system. And then the veins, right? The walls are thinner than arterial, but you still have the same 3 layers, and they have the flap-like valves. So blood pressure is, I mean, we think of the term blood pressure, we always typically is referring to systemic arterial pressure, right? But really blood pressure is just the force that's exerted on the inside of any blood vessel. So you have blood pressure throughout the whole cardiovascular system, but if you're saying somebody has high blood pressure, that's referring to their systemic. So like coming off the aorta, arterial pressure. So the arterial blood pressure, it rises and falls, and this pattern corresponds with the cardiac cycle. So your systolic pressure, this is the maximum arterial pressure during ventricular contraction. So we said last week, ventricular contraction is known as systole. When the ventricles are in systole, the 2 atria are in diastole. Okay, so this is saying when the left ventricle contracts, that's going to cause the blood to exit the aorta, and then that's your maximum arterial pressure, right? Then the ventricles are going to relax, and then that's your diastolic pressure, or the minimum arterial pressure reached during ventricular relaxation. So when the ventricles are in diastole, there's still pressure in the vessels, like how much pressure is there. Now, if your diastolic pressure is high, think about what happens when the ventricles are going to go to contract. They're going to have to contract with more force to open up the semilunar valves, right? So the aortic and pulmonary semilunar valve. So high diastolic pressure is going to cause, high blood pressure isn't good, but typically high diastolic pressure is what's going to cause the heart to overwork, right? I don't know, I like this word, sphygmomanometer, right? So that's a device that's used to measure arterial pressure, and a blood pressure of 120, right, systolic over 80 diastolic at rest is considered to be normal. And so if you're your blood pressure is going to fluctuate throughout the day depending on like your activity level. And we mentioned that there's like baroreceptors that are found in the aorta and the carotid sinus, and they're going to, you know, be sending signals to the brain, to your cardiac center, which is going to try to maintain a normal level of blood pressure. You know, like you run up a flight of steps, your heart maybe is beating faster for a number of seconds and then goes back to normal. But if your blood pressure is elevated all the time, that kind of becomes the new normal, which can cause the heart to have to work harder. This is like the only muscle in the body you don't want to work hard, because the myocardium, those cells will increase in diameter, and then what that does, there's less space inside your ventricles if your myocardium becomes bigger, and so you can't pump as much blood out per contraction. So your heart's going to need to pump faster, right? Faster to eject the same amount of blood. That's not good, right? Can your blood pressure be too low? As long as this rules, as long as you remain conscious, it's good. Sometimes people like, especially like if they're a little dehydrated, if your blood volume is lower, that can cause your blood pressure to be a little bit lower. So if you wake up in the morning and you're a little dehydrated and you like sit really quickly, some people get lightheaded because their blood pressure maybe is a little bit low, and change in position can also affect your blood pressure or cause nosebleeds. Anyway, right? So the alternating like expansion and then snapping back or recoiling of the wall of an artery as the ventricles contract and relax, this can be felt at certain like superficial arteries, and then that's your pulse, right? So when someone takes, I like my carotid arteries personally, my neck. So common pulse points, like you can use your wrist, right, for your radial artery, your neck, your carotid arteries, upper in the your arm, your brachial artery, or your femoral arteries. So these are common like pulse points. It's just some like other areas where you could detect pulse. Sometimes they'll go to the dorsalis pedis, or like arteries on the feet, if an individual may have some circulatory issues, to make sure you can feel a pulse. You should be able to get a pulse. I'm trying to do this. It's not working. Trying to get a pulse in my foot. Pulse in your foot. I don't know. I like carotid. It's kind of like my go-to. So this is showing like in your aorta, you would have like the 120/80. And then you can see that the pressure drops, pretty significantly, like once you get into arterials. And then when you're in the vena cava, it's like almost zero. So you're really depending on the presence of valves in the skeletal and respiratory pump to return blood to the heart. All right, so we did blood vessels in labs. So this is just saying we're not going to go over like naming of blood vessels again. Oh, for all you embalmers, this is supposed to be main arteries used in embalming. Does anybody have like a favorite go-to artery? No. All right. Anyway, certain arteries that can be used in embalming. Oh, so we're done with this. Okay, so now I gotta go to. Oh, I want to. All right, let me. This is a Blackboard. I had a handout, but now we have no handouts. But I will put the answers in. Blood typing mystery patients. Oh. What happened to donor one? Uh-oh, I lost a donor. How did I lose a donor on my work? The worksheet had a donor one. All right, maybe we don't need donor one. We'll see. All right, so this is just saying like, just like practice again, like with doing blood types. All right, so we have an athlete. That collapsed during a marathon with severe dehydration. So they had a agglutination with the A and agglutination with RH factor. Anybody tell me the blood type? So look at which ones have the green checks. Let me do the first one. That makes them A positive, right? Whatever glutinase, that means you have those antigens. So we go down the bottom. Ooh, we got donor 4. Donor 4 is A positive. So they can get blood from donor 4. Bing. Okay. Patient 2, a car accident victim, arrives unconscious after a car crash. Needs immediate transfusion. All right. If the only well that agglutinates is the B, anybody think what their blood type would be? I know you guys aren't shy. I know there's no one shy in the class. Everyone's hands are up. I heard somebody say,
Is it A?
right? So you just read the wells that are agglutinating. The only one is B, so that makes them B automatically, right? So if the B well agglutinated, that makes them B. If the RH well didn't, they're B negative. So let me know in lab Thursday. It's never going to snow again. We can go over this again. So they're donor 5. I know it's like counterintuitive to what you would think. All right, all right, so where it says, all right, so the next person, they didn't have a reaction with A, they didn't have a reaction to B. You could also read it. That means they have no A antigens, they have no B antigens. If you have no A and B antigens, you are type O. Yay, so I said O. And it says they have an RH factor, so they're O positive. O positive. I think there's like 1 or 2 questions on the test like that we don't want to like over chill it. So you give them 2. So if you have agglutination in A, B, or H, so just like read what the green checks are. So they have A, B, and for RH you get a positive. So they're AB positive. Oop. They could get donor 8. Right. All right, so for our test next Tuesday, let me make sure. Stop sharing. Make sure I go to Blackboard. Some people, I don't know if this is something you'd be interested in doing, right? So there's regular paper review sheet that just gives like an outline of everything we covered. There's Quizlet review. If you like Quizlet review, you can click on that. And then that goes to like a Quizlet review on the cardiovascular system. How many cards are there? Like 96 cards. And then another thing, I don't know if you ever tried Google Notebook. You can use Google Notebook. You can also use Copilot, which use this tab instead. Does that make sense? So you can use Copilot, which comes free with Office 360, or if you have a Google account, you can use this for free. And what I did is I just like uploaded the review sheet into this, and then I don't know if the audio overview sometimes takes a while to load. But it's funny, it like reads through like everything that's on the review sheet. It's saying it, but I don't hear it. Why don't you hear it? Deep dive. Yeah, it does like a lively conversation between two hosts. That one cracks me up. It does like, you know, a bite-size overview, does critiques. So this, it actually like, it's like two people talking about like what was on the review sheet. They do like video overviews. So there's like different, if you like to review things differently, like it can do quizzes. All right, let's see if we can get the quiz to work. They can do like slide deck and do flashcards. It does take a little while to load though. You know what I remember to do? I have to remember to like hit. Okay, we stop recording.